Today, inshallah, the title of our lecture will be Plastic, Periodontal and Aesthetic Surgery. First, I want to define what I mean by periodontal plastic surgery. It is the non-pocket surgical procedures performed to correct or eliminate anatomic, developmental, traumatic, or plaque disease defects of the gingiva, alveolar mucosa, and the bone. These include the following surgeries: gingival augmentation, coverage of the denuded root surface, removal of the aberrant frenum, crown lengthening, preservation and augmentation, reconstruction of papillae, aesthetic surgical correction around the implant, surgical exposure of the unerupted teeth for orthodontics treatment. In this lecture, inshallah, we'll discuss the gingival augmentation, coverage of the denuded root surface, removal of the aberrant frenum, crown lengthening in details, but preservation and augmentation and reconstruction of papillae in short, and number 7 and 8 not included in our lecture. First, I want to remind you about the anatomy of the gingiva. We start the gingiva with crest of the gingival margin and gingival groove around 1.5 and 2 millimeter. This is the distance between the crest of the gingival margin and the free gingival groove, and called it free or marginal gingiva. From free gingival groove till the mucogingival junction, we called it attached gingiva, and after this the alveolar mucosa. To determine the width of attached gingiva, we measure the distance from the crest of the gingival margin till the mucogingival junction, and subtract from it the depth of the periodontal bucket or the gingival sulcus. As you notice that gingival width of attached gingiva differs from one to another. Here is the width of the attached gingiva: wide, moderate. Here, nearly no amount of attached gingiva. The amount of attached gingiva usually differ from side to side in the same individual, may be found wider in the anterior region and more narrow in the posterior region, and may be differ from in the same individual from time to time. During healthy, differ than during disease, periodontal disease. During periodontal disease, due to the increased depth of the periodontal bucket, the amount of attached gingiva decreased. Factors that lead to decrease the width of attached gingiva, as I mentioned in the previous slide, the amount of attached gingiva from starting is insufficient. The second factor may be the presence of gingival recession. The recession reached to the mucogingival junction, and deep periodontal bucket that may reach to or beyond the alveolar mucosa. We have to test to show that the amount of attached gingiva is insufficient. When we want to test the lower anterior teeth, for example, make stretching test by stretching the lip, and you find that the alveolar mucosa stretch the gingival, the attached gingiva, and the gingiva as you see is bleached. Okay, this is mean that the amount of attached gingiva here is insufficient. Another test is making rolling test by using the periodontal probe, side of the periodontal probe, and try and put it on the alveolar mucosa and try to roll it coronally. You find that the amount of attached gingiva here is bleached. This means that no amount of attached gingiva here. The difference between attached gingiva and alveolar mucosa: the attached gingiva is firm, resilient, and tightly bound to the underlying periosteum of the alveolar bone or tooth surface. Attached gingiva is keratinized to serve as a barrier against damage that may occur during eating from trauma, chemical stimuli, or thermal stimuli. Alveolar mucosa, not keratinized, and mobile mucosa, they can provide great flexibility during chewing, speech, and facial expression. Oral mucosa not designed to serve the function of the attached gingiva. Widening of zone of attached gingiva accompanies the following three objectives. Number one, enhance plaque removal around the gingival margin. Second is improve the aesthetic. Third, reduce inflammation around the restored teeth. Indication for the gingival augmentation. Why I need to increase the width of attached gingiva? Number one, area with a progressive or progressing gingival recession. Prior to orthodontic movement in area with a thin labial osseous plate, in conjunction with a fixed or removable prosthetic dentistry. Discomfort or difficulty during tooth brushing. Individual with inadequate oral hygiene. This is the indication of gingival augmentation. We have two techniques for increased attached gingiva. The first one is gingival augmentation apical to the area of recession. The graft either pedicle or free. Pedicle means the base of the graft is still attached to its original place, but free means the graft transferred from place and put in another place outside اللي هو recipient site. Gingival augmentation coronal to the recession means we cover the recession, either also pedicle or free, placed to cover the denuded root surface. Both the apical and the coronal gingival augmentation widen the zone of attached gingiva and enhance the oral hygiene procedure. But gingival augmentation coronal to recession solve aesthetic problem اللي هو recession يعني. Techniques for gingival augmentation apical to recession, we have three techniques. The first one is free gingival autograft, the second is free connective tissue autograft, the third one is apical positioned flap. Free autogenous soft tissue graft. As we mentioned before, free means transfer the graft from side to put in another side. Autogenous means in the same individual. Soft tissue autograft. We have two types, epithelialized connective tissue graft and connective tissue graft. What is the difference between both? As you know, the gingiva composed of three layers. The superficial layer is epithelium, underlying the epithelium is connective tissue and periosteum. Under the connective tissue periosteum. If we take the graft including the outer layer of the outer surface of the epithelium and the part of the connective tissue, we call it epithelialized connective tissue. If we leave the epithelium intact and take the graft only from the connective tissue layer, we call it connective tissue graft. For the free gingival autograft, the first step is to prepare the recipient site. When we make pulling test by the lower lip, we find that our stretching test, we find that the bleaching of the gingival margin around the lower teeth. This means that insufficient amount of attached gingiva or absent of amount of attached gingiva. If we left this without treatment, the recession become worsened. Then we make planning for the incision site. Start the incision site with the horizontal incision by using a scalpel number 15. The depth about 1 millimeter. After finishing the horizontal incision, you noted that the amount of bleeding is minimal. This is because the amount of the vasoconstriction of the local anesthesia. Then, by the scalpel number 15, by oblique direction, make dissection for or cutting for the connective tissue fibers to avoid injury for the periosteum. Then we make suture, disposable suture from the lower margin of the mucosa with the periosteum. Then apply a sterile tin foil to make a pattern for the graft. Then obtain the graft from the donor site. We noted that when we try to take the graft, we have to do it in the same direction, on the same side, in the same side of the recipient side to avoid pain on both sides for the patients. Put the tin foil in the palate away from the gingival margin about 2 to 3 millimeters, away from the rouge area and away from the soft palate. By using the scalpel, make outline for the graft, then make embolization for the graft and complete removal of the graft. After removal of the graft, put it on the sterile tin foil. Take care to know the epithelium from the connective tissue side. Apply the graft and take care to put the connective tissue side toward the porosity and the epithelium toward the outer surface. Then make suture and complete the suture, and after finishing the suture, apply pressure with your finger about 2 to 3 minutes to avoid too much clot formed under the graft, because this is prevent attached of the graft to the recipient, the bedside, to the periostea and maybe make infection, because the blood clot act as a nutrient for microorganisms. Return again to the donor site. We use acrylic stent for the area of the graft at the donor site. Cover the area of the graft with a gauze with analgesic to prevent pain for the patient and prevent the pressure of the stent, prevent bleeding and prevent pain and bleeding and discomfort during eating. This is after 3 to 4 days after surgery, and this is after 7 or 10 days, and this is after 5 years of healing. And you noted that the pale color of the graft still after, and this is the disadvantage, one of disadvantage of the free gingival graft. Healing free gingival graft, starting from day 0, the day of the surgery, 2 days after, plasmodic circulation occur. After 3 to 7 days, revascularization. After 4 to 14 days, histologic organic union occur between the connective tissue of the graft and the porosity. We have several variant technique. The first one is Occordion technique. The second is strip technique, combination technique. Occordion technique, when we have large area with insufficient amount of attached gingiva and the difficulty to obtain the large graft, we take a graft from the donor site as I mentioned before, and make alternate cutting in the graft and put it in the surgical site and make suture, and this is after healing. Also the pale color after healing. Combination technique. Combination technique, as I mentioned before, the thickness of the gingival graft must be around 1 millimeter, because too much thickness prevent diffusion of the nutrients and vascularity to the area and make failure for the union. And too thin graft also shriveling and may be cut away. Combination technique, we remove a strip of the tissue, too thick tissue, about 3 to 4 millimeter thick, and split it longitudinally by the scalpel, both used as a free graft. The superficial one consists of epithelium and connective tissue. The deeper one is connective tissue only. After this, we apply in this area like this and make suture. Connective tissue graft. As we mentioned before, the connective tissue graft contain only connective tissue without the layer of the epithelium, and this is contained from the underlying flap of the palate by making two incisions in the palate, one more superficial and the other deeper, and withdraw the graft as we see and transfer it into the recipient side and make suture in the donor side, and healing here in this donor side by primary intention. And this is one of the advantage of the connective tissue graft. When we make comparison between free connective tissue graft and free gingival graft, we find that healing in the donor side of the connective tissue graft occur by first intention, but in case of free gingival graft, the healing by secondary intention. So for connective tissue graft, less discomfort for the patient post-surgically at the donor side, but in case of gingival graft, the discomfort after post-surgical is more in because the healing by second intention in the gingival graft. Connective tissue removed to graft removed to thin the palatal flap can be used as a graft tissue to augment area of recession. Better aesthetic. As I mentioned before, when we saw the slides after 5 years healing after gingival graft, we find the color of the gingiva is pale pink, but in this connective tissue, the aesthetic is better. This is the advantage of connective tissue than the free gingival graft. Connective tissue graft tunnel technique. This type of surgery can be used in cases of localized recession, and this start with this type of surgery by making a resection for the diseased part of the gingival margin or around the recession, and make scaling and root planing, and by using a scalpel make a tunnel under the gingival in the interdental area, and get connective tissue graft as I mentioned before, and withdraw this connective tissue graft under the tunnel and make suture, then it heal. The apical positioned flap, this is the third technique for gingival augmentation apical to recession. As we mentioned before, we have 3 types of surgery. The first one is a free gingival autograft. Second one is a free connective tissue graft, autograft. The third one is apically positioned flap. As you know, in the lecture of periodontal flap, the flap may be after reflection retain it into its original place, or retain it apically or laterally or coronally. This type, to increase the width of attached gingiva, we use apical positioned flap. Apically positioned flap may be used partial thickness or full thickness flap. Partial thickness means after reflection of the flap contains epithelium and part of the connective tissue, and the bone is still covered with periodontal and part of the connective tissue. But full thickness flap means when reflected the flap contains the 3 layers: epithelium, connective tissue, and periodontal. Both can used to increase in case of apical position flap to increase the width of attached gingiva. But we noted that this is increase the width of attached gingiva, but not increase the depth of the vestibule. In this case, in case of apical position flap, we have we must have enough width of depth of the vestibule to allow for the apical positioning of the flap. This this case is apical position flap. We used called this is apical position flap to increase the crown lengthening surgery. In case of badly distracted tooth and insufficient amount of clinical crown and difficulty to prepare the preparation for this patient, we make crown lengthening surgery by making flap and reflect the flap, expose the tooth, and remove layer of the bone all around the tooth to increase the clinical crown, to permit the preparation and of the crown, and at the same time improve the aesthetic. But we have to notice that when we expose the area of the clinical crown, you have to leave a distance between the crest of the alveolar bone and the finish line of the preparation, your preparation, about 3 millimeters, and this is called a biological width. This is crown lengthening procedure by apically positioned flap. This is after suture and this is after healing. Gingival augmentation coronal to recession means when we put the graft, we put to cover the root recession. This solve several problems. The first one is solve aesthetic problem by recession, caused by recession. The second is widen the zone of attached gingiva, and this facilitate removal of the dental plaque. The third is manage the defect result from the exposed root surface and caries that may occur or cervical abrasion, and also reduce root sensitivity. Before discussing the techniques for the gingival augmentation coronal to recession, we have to discuss first the classification of gingival recession. We have simple classification by Sullivan and Atkins. Simply, one means the recession is shallow and narrow. The second is the recession is shallow and wide. Third, the recession deep and narrow. The fourth, recession deep and wide. But we have another classification by Miller's. This is Miller's classification. Class 1, marginal tissue recession does not extend to the mucogingival junction. There is no loss of the bone or soft tissue in the interdental area, and may be shallow narrow or shallow wide. Class 2, marginal tissue recession that extend to or beyond the mucogingival junction, but there is no bone loss or soft tissue loss in the interdental area. Can be subclassified into wide and narrow. Class 3, there is marginal tissue recession extend to or beyond the mucogingival junction. There is bone and soft tissue loss interdentally, but not severe. There is malpositioning of the tooth. Class 4, there is marginal tissue recession extend to or beyond the mucogingival junction with severe bone loss and severe soft tissue loss interdentally with severe tooth malposition. This is Miller's classification. As you notice in class 1, the marginal recession not reach to the mucogingival junction, and the interdental papillae no intact and no bone loss. Class 2, the recession may reach to the mucogingival junction, but the interdental area intact and no bone loss. Class 3, the recession may reach to the mucogingival junction, and we have bone loss and interdental and bone loss, interdental bone loss, but not severe. Class 4, the marginal recession reach to or beyond the mucogingival junction with severe bone loss and severe interdental loss. Prognosis of gingival recession in class 1 of Miller's classification, class 1 and 2, good to excellent prognosis, because we have no bone loss and the interdental area intact. Class 2, only partial coverage can be expected when we have partial loss of the bone and partial loss of the interdental area. But in class 4 with severe bone loss and severe interdental loss, very poor prognosis. Techniques used for gingival augmentation coronal to recession. We have several techniques. The first one is a free gingival autograft, second one free connective tissue autograft, third one is pedicle autograft. Pedicle autograft classified into lateral position, double papillae flap, coronal position, semilunar pedicle graft, guided tissue regeneration, pouch, and tunnel technique. Free gingival autograft, as we mentioned before, we have localized gingival recession. We make scaling and root planning and resect all marginal part of the recession, diseased part of the marginal recession, and get the gingival autograft, as I mentioned before, from the palate, and put it coronal to recession and make suture, and this is after healing. Free connective tissue autograft to cover denuded root surface. As we mentioned in the previous slide, in case of recession, we remove all diseased margin of the gingiva around the recession and make scaling and root planning, and they get connective tissue graft from the palate, as we mentioned before, and insert the graft under the gingiva and make suture, and this is after healing. Lateral pedicle graft. Lateral pedicle graft, as I mentioned before, pedicle means the origin of the base of the flap is still attached to its original place. Lateral means we move the flap in lateral position. This is a type of the surgery is indicated only in case of localized recession related to single tooth and the neighboring tissue is intact. In this type of incision, in this type of surgery, we make the same, removed all diseased margin of the gingival margin and make scaling and root planning. This is a recipient site, prepared recipient site by this, and we try to get the pedicle graft by making vertical incision, extend beyond the mucogingival junction, away from the interdental papillae, to not cause deformity for the interdental papilla, and the vertical incision, as I mentioned, extended to beyond the attached gingiva, beyond the mucogingival junction, because if we stop the incision into the attached gingiva, we cannot move the flap or the graft, but extend to the mucogingival junction and make bending, extending to the mucogingival junction to the alveolar mucosa, permit or allow the movable of the graft or the flap. Make bending incision in the end of this to prevent tension of the graft, and move the flap laterally and make suture, and both will heal. This we can do this type of surgery by using partial thickness or full thickness, but we usually prefer to use a partial thickness flap, and the healing occur faster than full thickness flap. This is a case with a localized recession related to the canine, and this is the intact area. Then this is the recipient site, and this is the donor site. Make a vertical incision, as mentioned before, extend to or beyond the mucogingival junction, and move it laterally to cover the recession, the crown, and make suture, and this is after healing. Coronally positioned flap to cover denuded root surface. This is a very simple surgery. From its title, coronal positioned, يعني we make flap and positioned in the coronal direction. When we have recession related to these tooth, as you see, we make scaling root planning and make two vertical incision extend to or beyond the alveolar mucosa to permit or allow the movement of the flap or the graft coronally. And after making two vertical incision, make scaling and be sure the area is clean, and move the flap coronally to cover the denuded root and make suture. Note in this type of surgery, the interdental area is intact and no bone loss. Okay, and this is after healing. If we have bone loss interdentally or interdental area is not intact, we cannot reach to this result. Semilunar coronal positioned flap, we make semilunar incision, followed the curvature of the recessed gingival margin, and ended 2 to 3 millimeters away from the tip of the interdental papillae to allow the blood supply to reach the flap. This is very important. Then we make a split thickness incision from the gingival junction, sulcus to connect it with the sulcular incision. The tissue will, after finishing this incision, the tissue will collapse coronally to cover the recession, and no need for the suture or back. This technique is very simple and used to cover 2 to 3 millimeters of recession in the maxillary teeth, not in the mandibular teeth. This is for the aesthetic. Usually used this when gingival margin receded from recently placed crown margin. This is a semilunar incision and a partial sulcular partial thickness incision, and the tissue collapsed to cover the recession. Guided tissue regeneration. This type of surgery I didn't discuss in this lecture because in details you discussed in the lecture of regeneration by using the localized recession related to the canine, and used guided tissue regeneration and to improve problems associated with shallow vestibule. To measure the depth of the vestibule, it is measured by the distance from the gingival margin, crest of the gingival margin, to the bottom of the vestibule. Gingival recession displays the gingival margin apically, thus reducing the vestibular depth. Adequate vestibular depth width is necessary for proper oral hygiene procedure, زي مثلا for example sulcular brushing technique أو for proper placement of the removable prosthesis. Problems associated with aberrant frenum. Frenum becomes a problem if its attachment is too close to the margin. As you see in these figures, it is difficult for the patient to maintain good oral hygiene and place the head of the toothbrush to maintaining this area clean. This is the first one, and the second one is continuous pulling of during movement of the lip or during mastication. A continuous movement may pulling the frenum, may pulling the marginal gingiva away from the tooth and cause periodontal pocket formation or recurrent pocket after treatment. As I mentioned, surgical removal of the frenum is indicated because it is interfere with the plaque removal, inhibit proper brushing of the teeth. Tension on this frenum pull the gingival margin away from the tooth, and as I mentioned, cause periodontal pocket or recurrent or periodontal pocket after treatment. We have two types of two techniques for removal of the frenum. Phreniectomy and periodontal. Phreniectomy means is complete removal of the frenum, including attachment to underlying bone. Phreniectomy means incision of the frenum to become free. Ridge augmentation. We have to know first the classification of type of ridge deformities. Class 1, the defect of the ridge in the buccolingual width only. Class 2, loss of the apical coronal only on the height. Class 3, both width and height. This is the defective. Class 1, 2, 3. 1 buccolingual, class 2 in the width, class 2 in the height, apical coronal, and class 3 in both width and height. The correction of a reconstruction of the ridge may be corrected by soft tissue or hard tissue treatment. As you see, this is a pouch graft to correct ridge defect, class 1. As you see, the defect in the buccolingual, loss of buccolingual in the width. This is corrected by the pouch or tunnel technique with a soft tissue graft, and this is after healing. This is class 3, the defect in the height, as you see, and the width by graft, okay, and suture, and this is after healing and after placement of the teeth. Ridge preservation. After extraction of the tooth, the ridge collapse, decrease in the height and the width, and if we left for a long time, lead to ridge deformity as mentioned before, and need ridge augmentation to correct the defect. So now, after extraction of the tooth, we try to put bone graft or concentrate growth factor or another regenerative factors to maintain the ridge without collapsing or decrease in the height or width. Construction of the interdental papilla. In some patients, loss of interdental papilla may cause a problem, aesthetic problem for the patient, and make the black triangle between the teeth. And this can be corrected by two types of treatment: by alteration of the tooth position by ortho, or by soft tissue grafting procedure. This is papilla reconstruction by using soft tissue graft. As you see, black incision in the base of the interdental papilla reflect the flap and put the graft and make suture. And this is the first figure. Notice the black triangle between the teeth, and after treatment, no black triangle between the teeth, and correct occur to the aesthetic. Crown lengthening. Crown lengthening is induced when there is insufficient length of the clinical crown or improve the aesthetic. As we discussed before, as you know, we discussed in the apical position flap, when we have no enough width of length of the crown, and make the flap and increase the length of the clinical crown to permit us to prepare the crown. And this is a gingivectomy procedure made for the patient to improve the aesthetic. This is, we called it pseudo crown lengthening, because we do not remove bone, only soft tissue removal to improve the aesthetic. This is the references. Good luck for you. Thank you.